Hello, everyone. Thank you for joining us today for the Robert Wood Johnson Foundation Systems for Action Research in Progress webinar. We're so glad you're here. We have some exciting research in progress to share with you today. My name is Sarah Brandspiegel. I'm the Research Engagement and Translation Director for Systems for Action. And some of you may be new to Systems for Action. If you're less familiar with what we do, Systems for Action is a signature research program of the Robert Wood Johnson Foundation. And we study ways to align and connect medical, social, and public health systems with a goal of improving population health and advancing health equity. So we support studies around the country that are testing a variety of different ways to connect, align, and integrate medical, social, and public health systems. And they cover a range of topics and alignment methods. If you want to learn more, you can check out systemsforaction.org. To learn more about more than 20 studies that we're supporting. Also, all the research in progress webinars are recorded and archived on our site, so you can watch other research in progress webinars there that you may have missed. But these webinars serve as an opportunity for our grantees to share the innovative work that is in progress. And we feature studies at every stage. So from the early phases when projects are just beginning to later in the process when they have findings. And today we're going to hear from a project that's led by a team at Georgia State University that's looking to answer the question, can subsidized transportation options slow diabetes progression? This project recently launched, and so we look forward to hearing more about the background, the research design, and the work that they have planned. I want to encourage you that if you have questions throughout the webinar, please enter them in the Q&A box, and we'll have time at the end for questions. So I'm going to introduce all of our speakers and then turn it over to them. First, we're going to hear from Fei Li. She's an assistant professor in the Urban Studies Institute at Georgia State University. Her work explores how individuals and markets react to and interact with policy, and she has extensive research interests and experience in transportation and mobility research. And then we're also going to hear from Chris Wichikowski. He's a postdoctoral researcher with the Urban Studies Institute and Disaster Smart Schools at Georgia State University. He's an urban policy scholar with research interests related to the interaction of society with the evolving urban environment. And in his current role, he organizes cross-university research collaborations addressing complex urban problems related to mobility and access in cities. And then finally, we'll hear from Katie Mooney. She works in Grady Health System's Planning and Business Development Department, where she serves as the Community Benefit Manager. And in this role, she oversees the development of the Triennial Community Health Needs Assessment and manages the implementation of the Community Health Improvement Plan. She works across the health system and with a range of community partners to strategically align resources to improve both patient and community health. So thank you all so much for being here to share your work with us. And now I'll turn it over to our presenters to talk a bit about their project.
All right, thank you so much, Sarah, for that introduction. Just got control, I think. And good afternoon, everybody, or good morning, depending on where you are. I am Faye. I'm really glad to be here, and thank you all for joining us at this webinar. This is our first research in progress presentation. We are still early in the stage of this research study, so we'll be mostly talking about the background research design and the plans for next stage of work. So about a year ago, Chris and I were examining the impact of transportation as a social determinant of health. From what we observe in the literature and from local communities that we see, lack of transportation can be an important factor that stops people or prevent people from getting access to healthcare, healthy food, and other services and activities that can be fundamental to their health and well-being. We also located in one of the cities, Atlanta, one of the metropolitan areas with the starkest health disparities in the country. There's significant racial segregation in the city and very stark divide in terms of socioeconomic status and racial combination, and of course, health outcomes. One of the triggers that motivated our study was a map that showed the different life expectancies across US cities, and for Atlanta, we see the difference between the lowest and highest income communities were over 10 years in life expectancy, and that seems to indicate a lot of premature death and medical conditions that could have been better managed and treated given better resources. And we think transportation can be one of the factors that we can change here. Oops. Sorry, so what we learned from the literature is that there is pretty good evidence on how transportation barriers can hinder people utilization of healthcare, like contributing to missing doctor appointments, not following up with prescriptions, or relying on emergency care instead of primary, preventive, and routine care. This can be due to long distances from clinics and hospitals, pharmacies, or because of high transportation costs and lack of reliable transportation services. And this is not only costly to the individuals for their health, but also very costly financial-wise to the healthcare system because the increased usage of emergency care instead of primary care and missed appointments. Meanwhile, there's also abundant literature showing that lack of transportation is contributing to the limited access to healthy food by low-income households and so-called food deserts. So people living in these areas with no immediate access to healthy food options may be able to travel further to supermarkets or grocery stores with fresh produce, fruits, and vegetables, but they may also not be able to afford a car because these are mostly low-income communities or not even able to afford public transportation, or maybe there's simply not access to public transportation there. So that will lead them to be limited to less healthy food options like fast food, processed and pre-prepared foods. On the other side of the equation, we also see that public transit services can be absent or inadequate in low-income neighborhoods and transit-dependent neighborhoods. We also have a recent study that's actually using data from Grady Hospital, our research partner for this study, that shows over 70% of the senior patients in the geriatric clinic report that they're not driving. So that shows that the personal mobility of many at-risk individuals is actually very limited, and given the limited coverage of public transportation and access to other alternative travel modes, that can be a significant barrier in their healthcare access. What we don't see, or what's currently lacking from the literature, is solid evidence on how these transportation barriers actually affect health outcomes. So we see how they might affect people's behavior, but not many studies, if any, evaluated the eventual impact on health outcomes, either physical or mental health. We think two reasons probably contributed to this research gap in the literature. One is that it's not always easy to manipulate accessibility or mobility, and then in order to observe the potential impact on health outcomes. And of course, it will be unethical to create artificial transportation barriers, which would harm the research participants. And the other thing is that even if there are natural experiments or policy interventions that can be exploited in longitudinal studies, it's often hard to get access to individual level data, especially data for the vulnerable populations, to evaluate how those interventions or natural experiments affected health outcomes. So when we learned about the Systems for Action program, we were really excited because we see how this can be a great opportunity to actually test the causal linkage between transportation and health. So that's our number one objective with this research study, and the other one being to explore the effectiveness of alternative solutions, including but not limited to public transportation and utilization of existing resources. So we hope that on proving the causality between mobility and health, and on exploring and comparing how these different solutions could contribute to improving physical and mental health for vulnerable individuals, we might be able to promote actions from healthcare, public health, and social services systems to improve public health. So these are the 4 alternative solutions that we are going to explore in this research study. The first one we'll be using is to give free public transit rights. So we recognize that public transportation is not the only answer or solution here, partly because in some communities, the coverage or services is simply not sufficient, and partly because some individuals, like, for example, with disabilities, may not be able to utilize the public transportation available to them. Nevertheless, there was a previous program here in Atlanta led by some of our research partners, which Chris will be introducing just in a minute. That program was called Rights to Wellness, where they, Grady Hospital and Atlanta Regional Commission were providing some low-income patients with free public transit rights. So they obtained pretty positive feedback from that program, although it was not designed as a research study to evaluate health outcomes. So our second solution is to use rideshare credits on digital platforms such as Uber and Lyft, because we were interested in learning how these emerging new transportation modes based on new technology or smartphones can be used to address mobility needs of disadvantaged individuals. The third alternative is to just provide equivalent cash grant. So the idea is to give the participants the freedom to apply that small amount of money to whichever areas of their life that they need the money the most. And we will be able to use survey questions following their transportation budget and other major budgets in their life for housing, for food, to track how they actually spend that money, if that increased their budget for transportation. Fourthly, we will be using mobility counseling to another group of individuals, the aim of which is to provide better connection with existing resources and programs designed to meet the transportation needs of these low-income, chronically ill individuals. So that is what we think can be an innovative and very interesting approach to not provide additional monetary assistance, but rather make a better effort to connect existing systems to work better together to cover the mobility needs of at-risk individuals. So now I'm going to hand it over to Chris to introduce a little more about the mobility counseling approach and how we build a partnership with local nonprofit, public agencies, and private companies to align these systems together.
Okay, hi, this is Chris. Let me see how I get control of the slides. Okay. So as Faye mentioned, we think that one of the innovations that we introduce in our study is to actually compare these different enhanced mobility modes and introduce them to our study group. So not only are we comparing these different modes against each other, but we're measuring them on actual health outcomes, which is obviously there's a shortage of individual level data to get insight into how mobility can affect health. So I just want to mention that for our target group, which Faye will talk about a little bit later, we're going to be dealing with low-income populations, and public transportation provides about 60% of the public transit riders are actually minority and low-income populations. Households that earn less than $15,000 per year make up 13% of the overall population, but they make up 21% of riders. Ride-share credits are a disruptive technology, so we think that there's not enough evidence to see how that type of mobility can be used by low-income populations. Obviously, cash provides users the ability to select their own modes or subsidize other needs, which may also show up in health outcomes. And then finally, we have a mobility consulting solution, which we've borrowed from something called solution-focused therapy. It's also called solution-focused brief therapy. And the idea behind this therapy is to use the user's own experience to help them solve their problems. It's very much focused on the present and the future rather than dwelling on the past, although it does call upon the participants to think through ways that they have been able to alleviate their problems in the past and project that in ways that that this can be used in the future. So we think that this fits really well, for these participants in mobility counseling, because it's brief, it's short, and it ties well with helping them make transportation decisions based on their past. So we look at system alignment of several sectors. We look at medical care, which is costly and underutilized by low-income groups. And one of the reasons for that, we hypothesize, is lack of transportation, which creates barriers to access not only to healthcare, but also to food and other support systems, which may affect health. Then public health is just a broader view. We think that there are diminished overall public health impacts, and there are high costs from overuse of emergency infrastructure, such as emergency rooms and ambulances, 911 services. So we think that we can have an impact aligning these public health needs with transportation and also with food services. The last one is financial services. We didn't anticipate this one when we started out the program. However, it turns out that nationally, about 7% of people are not banked, meaning they don't have a bank account. But in Atlanta, that number is as high as 28%. And when we give out our benefits, for example, the cash subsidy or the rideshare subsidy, those actually require a bank account to function well. So we've partnered with Bank on Atlanta, which is a collaboration between financial institutions and community-based organizations and the local government to provide financial services which are inexpensive and therefore accessible to low-income individuals. So this slide shows our partners in this endeavor, and I'm going to talk about the major partners in this study, starting with our primary partner, which is the Grady Health System. It's the largest health system in Atlanta, and as you can see, many of their patients are either underinsured or have Medicaid. So the Grady Health System has a big incentive to reduce expensive ER visits, ambulance rides, and things of that nature, to help their low-income patients. And so Grady has created a food as medicine program, which is a collaboration with some community food banks to provide low-income diabetic patients with a food pharmacy, a healthy cafe, a farmer's market, and help them to learn how to utilize these services to increase better food intake and hope to achieve some health improvements in that way. So when we learned of this program, it was a very good match with what we were intending to do, is to choose public or transportation options to help improve health. So we're essentially going to be taking participants from people who qualify for this food as medicine program and utilize them as patients in our program. Our other partners are the Atlanta Regional Commission. So as Faye mentioned, the ARC promoted a Rides to Wellness program, which was in some ways a predecessor to our study, where they looked at, can the providing MARTA passes, MARTA is the system here in Atlanta, the public transit system, can that increase doctor visits, essentially. So the Atlanta Regional Commission is the planning unit in Atlanta. It covers the Cherokee, Clayton, Cobb, DeKalb, Douglas, Fayette, Fulton, Gwinnett, and Henry counties, as well as Rockdale and the city of Atlanta. As I mentioned, it's the planning unit, and one of the things that they're highly interested in is to encourage the development of healthy and livable communities. So they're an ideal partner for us in this endeavor. Secondly, ARCHI, which is the Atlanta Regional Collaborative for Health Improvement. It's an interdisciplinary coalition working to improve health in the region. And essentially what they do is they align with other nonprofit partners, look for funding, and prototype new ways of working together to promote health in the Atlanta region. And one of the things that will be critical for ARCHI as a collaborator in our program is to help disseminate the findings to the local community from this study. And then our partner is the MARTA system, which is a Metro Atlanta Rapid Transit Authority. It's the 9th largest public transit system in the United States. They operate heavy rail, bus, and streetcar systems. And the service area very closely overlaps with that of Grady Memorial Hospital, which is the counties of DeKalb and Fulton, which contain many of the vulnerable and low-income communities. So they are a key stakeholder in improving health in the Atlanta region because many of their, as I mentioned, many of their riders a majority of them are low-income and minority people who also coincide with our patient group. So we want to utilize these partnerships in the future to align funding mechanisms and form cost savings to help improve health in the Atlanta region. And here I'm going to hand it back over to Faye to discuss our actual study.
All right. Sorry, for some reason, whenever I click, it exits. All right. So like Chris just introduced, we were able to form this partnership with local agencies, banking services, public health, healthcare, Grady Hospital, and including their partners for the Food as Medicine program, where they will be providing free food to low-income patients in the primary care clinic. And we were able to get the support from the local public transportation agency, MARTA, and with alliances of other nonprofits and local stakeholders as like ARCHI, which allow us to better disseminate once we have research findings and reach further audience for promoting further action. So as we formed this partnership, it also became clear the target community and populations we were working with, which is naturally following how Grady Hospital was going to offer the food as medicine program to in the first stage, which will be for low-income patients with diabetes. This is a map showing this community served by Grady Memorial Hospital, which is located here. And as you can see, their serving populations largely overlap with the center of Atlanta, which is around here. And these areas also contain most of the low-income, socially vulnerable communities in Metro Atlanta. So there's actually a clear south-north divide. On the north side, there are more high-income communities and more gentrified communities, and the south side, that's where the most poverty and concentrated minorities communities are located in Atlanta. So this is a map showing the public transportation access for the same communities. And as you can see, there are these different services, some located in a little suburban outside counties in Cobb, Gwinnett, some other counties outside this map. But within where most our target population reside, which is in Fulton and DeKalb counties, MARTA will be the major provider of public transportation in this area. So we believe using MARTA as the public transit option in our study is appropriate. And as you can see, many of these neighborhoods, especially in downtown Atlanta and surrounding neighborhoods, there are pretty high percentages of the population without a car or private vehicles. So that also means many of these neighborhoods are dependent on public transit. And the blue lines here showed MARTA trains, which are not covering a lot of communities, but with MARTA buses, they do reach most of these low-income communities. Although we do observe and passengers report that like unreliable schedules or low frequency services can be a problem, including high cost. So each MARTA ride costs $2.50, and that's one-way trip. So a round trip will be $5, which can be a little high for many of these low-income households. So these are the intermediate and final outcomes that we expect from the study by providing those alternative transportation subsidies or counseling services. We expect to see increased utilization of primary care and reduced utilization of emergency care from the participants. We also expect to see more out-of-home activities and trip making, presumably because now they have this supplemental income or budget on transportation. We expect to see more physical activities because sometimes these people do need to get out of home and maybe to travel to participate in some physical activities. We expect to see more grocery shopping trips and more consumption of fruits and vegetables. So these are all the potential pathways we expect to lead to better health outcomes. And those health outcomes will be measured in terms of both mental health, in reduced depression, financial anxiety, and improved physical health, in better management of their diabetes conditions and related conditions such as obesity. So this is a conceptual model where we expect the mobility support from this program, the 4 alternative mobility assistances, as well as the dietary assistance from Food as a Medicine program will help improve dietary behavior in our target patients, while the mobility support should also help them with better healthcare utilization and more activities that contribute to better physical and mental well-being. So all these pathways can lead to better physical and mental health outcomes. The eligibility of the program depends on both the criteria of joining food as medicine program and also our set of eligibility criteria. In order to participate in food as medicine, the patient has to be seeking primary care at Grady Primary Care Clinic with uncontrolled diabetes and with food insecurity, which is also an indicator of low income and poverty. And further on top of that, in order to join our research study, they have to be 18 years or older, and they have to be able to make independent decisions and be able to speak and read English. This is in order for them to better utilize whatever support we provide to them. This is the flow chart showing mostly the research design and how it will progress. So basically, we're designing a randomized controlled trial to test all four alternative solutions and compare them to a fifth control group. And we decided that each group will have 120 participants, which bring the overall sample size to 600. We will offer the recruitment flyer and informed consent form to every participant that's entering the food as medicine program to give them a chance to opt in. And at the time, they will also complete a baseline survey on their travel behavior, behavior related to like trip making for different kind of destinations, physical activities, fruit and vegetable consumption, and healthcare utilization. So after that, we will randomly assign them to one of these 5 groups. And like we introduced before, one of the groups will be receiving free public transit rides. One of the groups will be receiving rideshare credits from Lyft. A third group will be receiving a certain amount of cash every month, and the fourth group will have access to free mobility counseling services. The fifth group will be a control group that will receive a final compensation for their participation in the surveys at the end of the study. So every group will complete a follow-up survey every 3 months along the study, and every participant will stay in the study for a period of 12 months or until they finish a 5th survey. So we limit the number of public transit rides to 10 rides per month, which is equivalent to $25 subsidies. This is partly based on the amount of funding available that we have, and also because we believe that 10 rides per month, given that they will have to come to the food pharmacy twice a month. So we think that's a good range of transportation support that allow them to cover trips to and from the food pharmacy, as well as some additional trips. So for rideshare, because every trip will be a little more expensive, it can cover probably 3 to 5 short trips, but it will be more flexible, so they can use that for whatever purpose they prefer to, and it could be door-to-door instead of them having to go to a public transportation stop. So it gives us the same amount of money for the cash group, and we'll observe how they choose to spend that money. This is the timeline and current progress. Because the study, and especially the food as medicine part, depends on the conversion of the research site or the food pharmacy from a previous McDonald's. So that progress has been slowing down our launch date a little bit, but we also, because of that, we had more time to develop and test the mobility counseling approach. We have already, earlier in the summer, obtained IRB approval and recruited staff for the program, and currently we are in the stage of training the personnel who will be administering the surveys and the counseling, and also to test, if we can, to test the mobility counseling approach in some similar communities and populations. We expect to start the experiment in January and start data collection for a period of 12 to 16 months, and then we will be analyze data and disseminate research findings afterwards. All right, so I guess I will hand over to Katie for commentary from Katie is from Grady Hospital, so she can comment more on the impact on the healthcare system.
Good afternoon. Can you guys hear me?
Yes.
Yep, you sound great, Katie.
Great. Thank you so much for having me. I'm Katie Mooney. I'm Community Benefit Manager at Grady Health System, and I'm leading our Food as Medicine partnership and working closely with the great team at Georgia State on this project. So just wanted to give a little context from the healthcare system side and, kind of why we're so excited about this project. It benefits our patients, our health system, and really the science and healthcare around social determinants of health. So with our patients in the Food as Medicine program, they have to, or we're asking them to come to the hospital several times to pick up food, to take nutrition classes, to take cooking classes. So it's a relatively intensive program that we're asking them to participate in. So having that transportation support is critical for them to be able to be successful, since we know that these are patients who have screen positive for food insecurity, so are most likely low income and may also have transportation barriers. So just that providing that service alone is really valuable to our patients and the patient experience as part of the Food as Medicine program. It's also really beneficial to our health system. We know that transportation is a significant challenge among much of our patient population, but we don't have a lot of information around that. What does that look like exactly? What are the barriers? So this pilot, this study will help us gather more information about what are those specific challenges that our patients face and help us as a health system better be able to address that in the future. It is also important because as a health system, we're not a transportation provider, so we would like to be able to bring more folks to the table to be able to help us address this issue. The well-being and health of our patients is a benefit to lots of stakeholders in our city and in our community. So building up the evidence for why addressing transportation in partnership with healthcare is really critical to building a system that ensures that our patients can be healthy and well. At Grady, we also have a vision of becoming the leading public academic healthcare system. So being involved in studies like this with Robert Wood Johnson Foundation and Georgia State help us to really become a leader in the academic healthcare field. And we're excited that this is a relatively new type of project for us. We have lots of research, but it is mostly medical and clinical focused. So this is a great new avenue for us to be exploring. And then finally, just the benefit to developing the science and healthcare interventions around social determinants of health. As we all know, that's a quickly growing need in the healthcare system, and we, as a safety net, especially need to develop those interventions and those partnerships to address how we're best serving our patients in the social determinants, and other safety nets and other healthcare system partners, insurers, all of the folks in this field. It's going to be helpful to have that evidence around how are we addressing social determinants of health for our patients. So I'm really excited that this study will be able to contribute to that, and that Grady will be a part of this project. So again, this is really important to us. I'm happy to answer any other questions around the healthcare perspective, but I will hand it back to Chris and Faye and our moderators to finish us up.
Great, thank you, Katie. I think we can move on to questions and answers at this point. We do have some questions coming in to the Q&A box. Please feel free to add your questions there, and I'll share them with our panel, and they can take them as appropriate. So first, someone asked about how do you define uncontrolled diabetes, and how are you measuring changes to patients' medication regimen related to diabetes for the study?
I can take that. We are defining uncontrolled diabetes as a A1C over 9, and that's how we define uncontrolled diabetes across our healthcare system for all of our population health initiatives related to diabetes. And how are we monitoring changes in medication? We are actually in the process of kind of developing that right now as we're building the Food as Medicine platform in Epic. We are hoping to have a way to measure and pull from the medical record if a patient's medication is changing, and so we're working with Epic to figure that part out, but I can't speak to that specifically yet, but I'm happy to share more about that if someone wants to specifically reach out to us as we get our Epic builds finalized.
Okay, great, thanks. And another question, you mentioned food insecurity as an eligibility aspect of the study. Can you talk about what screening for food insecurity looks like and what tool you'll use for that?
Sure. So we are using the Hunger Vital Signs 2-question screener that has been validated, and that is incorporated into a full social determinants of health screening at Grady. It's about 10 questions that ask about housing, transportation, substance use, and maybe a couple other things. So that is being rolled out as we speak. Several clinics have been trained on that, and will be fully rolled out over the next 6 to 9 months in all of our outpatient settings, and then we'll also be rolling it out in the inpatient setting as well.
Great. And lots of interest in the Food as Medicine platform. We have a question about, as you're developing the platform in Epic, will that be a module that can be implemented by other health systems that use Epic? Do you see this as something that could be transferable to a different health system?
Potentially, yes. So it is being built in Epic. So I am not super familiar with how all the builds work, but we're building it in. So it's a referral from the clinic to the food pharmacy, and then an episode will be created in the food pharmacy to track all of the different components. So I'm sure our Epic folks would be happy to share what they've built in with other folks who are on the Epic system.
Wonderful. And lots of questions coming in, so please continue to add your questions. There are a few questions about the various transit cards and cash subsidies, and will you be tracking how people are using those, whether they're using them to actually attend clinic visits? Is it totally up to them how they use those? Can you all talk a little bit about that process?
Sure, I can talk about that. So we don't specifically, so in our informed consent form, as well as the following like instruction materials, we advise patients that we encourage them to use those funds for health-related trips, but we don't require that, and whatever they want to use those funds on will not like affect their participation in the study. We do hope to obtain some of that information from, say, MARTA, Lyft, our partners that we're using their transportation services, but that will depend on to what extent they can share user data with us, so we can observe how people actually used those money or rights. But the idea is that because we in the consumption model that we showed before, there are different pathways lead to better health. Healthcare is one of them, and including healthy food and also access to other locations. And we expect, even if they don't even if they choose not to use the money for going to the hospital, they might actually use the money for some other purposes that could be beneficial for their health as well. So if they turn out not to use primary care more, or not to be more consistent with their doctor appointments, then that will be a finding as well. So maybe in that case, transportation barriers may not be the reason why they're not doing so.
Okay, great, thanks. Now we have a question from Amy. She asks about the fact that AMA is working with a major insurer to add billable CPT codes that cover social determinants of health, like food, transportation, and housing. And she wants to know, like, what the value of the investment to the hospital or the clinic would be. How would you show the value? What return on investment would a hospital or a clinic need to see, and what type of metrics need to be set up to measure the value of transportation subsidies and other things addressing social determinants of health? How do you see your hospital system thinking about return on investment and whether to continue a program like this if it does show an effect?
I would say specific to transportation, no-show rates are a major issue for the health system, and that if we see a transportation program having direct impact on decreasing no-show rates, that has a specific financial benefit to the health system. And so I think that would be one measure that they would look at to consider investment in continuing a program. I think with this project specifically, since it's part of the Food is Medicine project, goal of the Food is Medicine program is to address both food insecurity and chronic disease, specifically starting with diabetes. So if we can prove that the transportation is a critical component of the program for people to be able to participate, and then through the program we're able to, if we see reduced A1C, reduced utilization of inpatient care or emergency department use among the patients that are enrolled, those would also be significant financial wins for the healthcare system. So this, transportation is one of many pieces of this project, but if we can show that it's a critical piece, I think the health system would be willing to invest.
Okay,
and I think we do see it as a shared cost. Like the Food is Medicine partnership, we're partnering with Food Bank and Open Hand to address food insecurity. It's not something that as a health system we can do on our own. So I think similarly, transportation, we would want to see other partners also investing and helping to support this type of work among our patient population.
Okay, great. We also have a group of questions coming in about rideshare use in your population. Folks are curious if there are concerns about your patient population being able to use rideshares. Certainly having a smartphone, I think, is an important piece of that, and people's comfort level with using rideshare. How have you thought about the acceptability of rideshare within your population?
Yeah, that is a very good question, because it's a very significant piece of discussion in our forming the partnership, determining how to deliver the benefits. And this is where the banking services came in, because we were aware that many of our target population, low-income individuals, may not have a card, a debit or credit card. They need to sign up for Uber or Lyft. They may not have a smartphone, or they might be wary about certain such technologies or apps. So one thing that's promising is that Lyft is currently working with our city on the grocery access program. So the goal there is to provide low-income individuals with some credit to get groceries. And they did encounter some of these problems, and it seems like compared to the lack of technology, like without a smartphone, those people might be more inclined to not have banking services or not have a credit card or debit card. So in order to address that, we started talking and working with Bank of Atlanta and First Choice Credit Union to try to figure out some low-cost or no-cost options for them to start using a banking account, a checking account, or to get a prepaid debit card. This is not only to use our credits, but also in the long run probably will help their financial health and planning. We are curious about our target population's acceptance regarding smartphone-based transportation apps and technology. So I think that would be an interesting finding on its own. Observing the emergence of more like different types of transportation modes, like e-scooters is currently being really popular in Atlanta, although we don't expect many of our patients will be able to utilize that. And different kinds of bikes, these so-called micromobility, personal transportation devices. And we think simply assessing how well these low-income populations can adopt these technologies will be interesting finding in terms of promoting personal mobility in the long run.
Yeah, I just wanted to underscore what this is Chris, what Faye said about the unbanked. So as I mentioned in when I was speaking, 28% of Atlanta residents are unbanked. So we see this as a problem. Also, there may be some bias on a part of the providers against low-income populations, as well as some of the low-income populations may have a bias against using rideshare for a variety of reasons. So we think that although it may hamper our study just a little bit in comparing if there's a lower uptake of rideshare compared to the other modes that we offer, I think there could be some interesting observations that we could make just in light of our patients using or not using rideshare, because some people have suggested that as a disruptive technology, it could replace public transit and things like that. So I think we'll be able to address that a little bit from our findings.
Wonderful. Yes, I think that will be really interesting to see how that all rolls out. I do want to put in another question here that came from Amy. She wants to know, how will you be able to separate out the contribution of different factors like transportation, access, but also self-selection and raised awareness from your outcomes?
I can talk a bit about that. I think that's a great question regarding the research design. So we believe that the utilization of RCT could rule out most of that regarding self-selection. Like, we cannot deny the fact that we are aiming a very specific population, and we are expecting that most of our participants select into our program because they need some kind of aid that we can provide. And actually, the probably more worrisome effect we're concerned there is selective drop out. So we're afraid that some participants that get selected into the control group will tend to leave the study because they don't really get anything over the course of the study. And that's why we provide this financial incentive at the end of the study to try to keep them. So in terms of the selection into the system, we don't claim that we are using a random sample or we're using like a representative sample population-wise, but we think the sample will be pretty representative to at-risk individuals that our approach is targeting, means low-income individuals with chronic illness, and with certain transportation challenges, either to get to their doctors or to other locations that they have to. But the utilization of random assignment should make each of these groups we're comparing pretty similar, if not equivalent. So that can address the selection bias in terms of comparing these different solutions. Sorry, just checking other parts of the question. So in terms of risk awareness, again, we think we conducting the research study at Grady alone will probably expose all the participants to this issue of transportation barriers, increased mobility. So we think that should apply pretty evenly across our sample as well. And I'm not sure if that answers Amy's question. Amy, do you have anything to add or follow up?
Yeah, Amy, feel free to add any follow-up questions in the chat. And I think we have time for one or two more questions. I am curious if you're going to be doing any analysis related to specific neighborhoods or the specific places where people live, knowing that, as you described it, there's a lot of variation in how accessible the public transit is around Atlanta. So will you be able to look at where patients are actually living?
Yes, of course. So we do ask questions in the survey about where they live, and they will also have that information in their patient records with Grady Hospital, and that should allow us to identify the accessibility to public transit, to other healthcare facilities and pharmacies and grocery options in their neighborhood. And maybe that's moderating factor in the causal linkage that we study.
Yeah, just along those lines, we're also going to be able to get from our counseling group, we're going to be able to get a little bit more qualitative information as our counselors work with these people. So rather than just having a survey, there's going to be a lot of recorded conversations that we can look back and identify other factors that maybe we didn't think of or weren't able to put into the survey.
Excellent. And there's a lot of interest in when you'll have findings. I know you're just beginning your study, but folks want to know, when will you begin sharing your findings? I think you had a slide that said 2021 is when you expect to have findings, but I'd love to hear what your thoughts are around how you'll disseminate those findings and share them. You certainly will be welcome to come back and do another webinar for us here, but I'm sure you have other ideas about how you will share this with the field.
Yeah, we do plan a workshop once the experiment concludes to share the research findings first with the local community and stakeholders, and hopefully we can invite some of the study participants to share their experiences as well. And after that, we'll be sharing findings through articles published with open access and hopefully conference presentations and maybe webinars again.
Yeah, one of our key stakeholders in this project is Archie. Essentially, their whole role is to disseminate information to health-focused nonprofit groups in Atlanta. So we very specifically targeted them as a partner to help us disseminate these things.
Well, wonderful. Well, we're just about out of time, and I want to thank you all again so much for coming here and sharing your project with us today. And for all our attendees, thank you for the rich discussion questions that you raised. And we will all look forward to hearing more about the project. I want to let you know about some upcoming webinars to be sure that you have on your calendar. November 20th, we'll have a research in progress webinar on closing gaps in health and social services for low-income pregnant women. And December 4th, we'll talk about strengthening the carrying capacity of local health and social service agencies to absorb increased hospital and clinical referrals. So you can register for these on the Systems for Action website. Also be sure to follow us on Twitter to get reminders about all of our upcoming sessions. And thank you again, everyone, for joining us today, and I hope you have a great rest of your day.